So we are doing a case from ODELL, case number 8, which is describing painful trismus. And this is case number, page number 45. So trismus as a general phenomena, it is reduced opening of the mouth. Usual opening is when we ask the patient to keep 3 fingers between the incisors, and that is the normal opening. And what all conditions trismus happens, we will see in this. So this is a 27-year-old woman who is unable to open her mouth normally. What is diagnosis and how should it be managed? Complaint: patient reports a sudden inability to fully open her mouth. And history of complaint being, the patient reports that 3 days ago, she was chewing a tough piece of meat and felt a sudden pain in front of her right ear. So it is acute 3 days before issue. Since then, she has not been able to open her mouth more than halfway. She reports an approximately 10-year history of intermittent painless clicking of her right jaw joint. Over the last few months, the clicking has become more painful and seems to be louder. So previous to sudden episode, which happened 3 days ago, she already had some chronic painless clicking of right jaw. Now she has experienced some hesitancy in mouth opening just at the position where the clicking is usually felt. She has not felt unwell at any point and does not report any symptoms indicative of infection. There is no history of trauma, recent dental work, or toothache. Medical history of this patient: the patient is otherwise well, other than occasional paracetamol or brufen, takes no regular medication. In her 20s, she suffered from few episodes of knee pain when she exercised, and the rheumatologist had diagnosed generalized hypermobility of her joints. Moving on, social history of this patient: she works at a marketing company and is a non-smoker. As a teenager, she was a successful gymnast. Family history, no relevant family history. So, extraoral examination: clinically well, aparexical, no fever, facial appearance symmetrical. She does not seem to be in acute discomfort. Acute discomfort can be severe lockjaw, okay? So it is, or severe redness, pain, and inflammation. The skin overlying her preauricular regions is of normal contour and without swelling. So usually if it is swelling and redness associated, it would be an acute symptoms. On palpation, there is tenderness over the right mandibular condyle and generalized bilateral tenderness of muscle of mastication on the right, which is masseter, lateral pterygoid, and temporalis. So bilateral tenderness on muscles of mastication on the right. What does it mean? That generalized tenderness bilateral of masseter, lateral pterygoid, and temporalis. One side, you see the kind of statement it is. Tenderness over the right mandibular condyle. So condyle-wise, only one side, and generalized tenderness of muscles of mastication of both sides. Neurological examination of her trigeminal nerve reveals no abnormalities, and examination of her fingers, wrists, elbows shows an increased range of movement with no tenderness or swelling. It is also supported by, she was a successful gymnast. So overall, she has hypermobility of her joints and overall skeletal system. Now, this is the appearance that she is trying to open her mouth to the maximum extent. And what do you see? The patient is asked to open her mouth as wide as she can, and she has noticeably reduced mouth opening. When measured between tip of incisors, opening is 23 millimeter. It should be 30 to 35 millimeter minimum. Okay, so which is less, and there is marked deviation to the right. When asked to move her jaw from side to side, lateral excursion on the right side is reduced. So there is some obstruction, some limitation in movement to the right side. It is 1 millimeter compared to left side, which is 8 millimeter. She is able to bring her teeth into maximum intercuspation, and she reports that this occlusion feels normal. What is differential diagnosis? The patient has trismus, and what is trismus? True trismus is defined as reduced mouth opening caused by spasm of muscles supplied by the trigeminal nerve. It was traditionally used to refer to the lockjaw seen in tetanus, which is infection produced by Clostridium tetani, but is more commonly used to refer to reduced mouth opening of any cause. So actual trismus is classically, it was restricted to tetanus, Clostridium tetani, but more commonly any reduced mouth opening. Now, trismus can be permanent or temporary, but most causes of true trismus are temporary. Let us look into what all the causes of trismus can be. Intra-articular causes and extra-articular causes. So internal derangement of the joint, that means the disc has moved, deranged from its position. Fracture of mandibular condyle, traumatic synovitis, avascular necrosis and bone necrosis and sickle cell crisis, arthritis, septic variant, osteoarthrosis, inflammatory arthritis such as rheumatoid or psoriatic, ankylosis, which is joining of the TMJ and the above scaphoid fossa, bony and fibrous, it can be any variety, secondary to trauma or infection, and lesions of the condylar head such as osteochondroma. Then we have extra-articular causes, trauma such as fractured mandible not involving in the condyle, post-operative removal of, so these were all inside the TM joint, okay? But outside the TM joint, what causes can be there? Trauma such as fractured mandible not involving the condyle, post-operative removal of impacted lower third molar, or recent prolonged dental treatment, misplaced inferior dental nerve block. This they give as a part 2 case in OSCE that you did LA, IANB to a patient, and now the patient comes back with swelling and trismus. So the reason is misplaced inferior dental nerve block. Acute infections of the oral tissues, especially involving the cheek or the muscles of mastication, usually odontogenic in origin. So any acute infection in oral tissues will reduce the mouth opening. Your all space infections will have trismus, okay? Ludwig's angina, maxillary space infection, the mouth opening will be reduced. Muscle spasm of masticatory muscles, as in myofascial pain. Then we have disease of masticatory muscles such as myositis ossificans or neoplasms. Scarring of muscles, skin or mucosa, as in submucous fibrosis or scleroderma, or after radiotherapy. Then we have inflammatory conditions of the oral mucosa, such as painful ulcers or other forms of stomatitis. And rare causes such as tetanus, Gaucher's disease, rare syndromes such as trismus, pseudocampo-dactyly syndrome, and central causes such as suprabulbar parosis and neonatal misoprostol exposure. These are very rare occurrences. If you remember the major ones, that is more than enough. Scleroderma is, submucous fibrosis, scarring of muscles is another important area to memorize for TMJ limitation. What are the common causes of pain in the TMJ? So these were all conditions listing internal causes and external causes of reduced mouth opening, trismus. Now they are saying causes of pain. In pain, TMJ pain is the common complaint whenever TMJ is affected, but much of that pain is referred to the joint rather than originating in it. Many of the above causes of trismus are painful, but most disease of joint is asymptomatic. Pathogenesis of painful TMJ disorders is poorly understood, and causes are notoriously hard to classify. So common three causes mentioned are osteoarthrosis, internal derangement, and TMJ disorder with myofascial pain. So osteoarthritis, arthrosis is basically non-inflammatory degenerative changes in the TMJ. These are similar to arthritic changes, but occur in the absence of severe inflammation. The cause has commonly been put down to wear and tear, but is probably multifactorial with a genetic predisposition and abnormal cartilage repair. So we have here absence of severe inflammation, but wear and tear is happening because of arthritis. And it's a genetic predisposition. Then we have clinically, the disease is characterized by clicking, locking, chronic pain, stiffness, reduced range of movement, and crepitus. There would be crepitus is something like sounds which is a bit continuous. Okay, it's a click is sudden, crepitus is like a blocked door, how it makes a creepy kind of a noise. It's hard to so crepitus is when it's not a sharp click like sound, but something is being frictioned against, that kind of sound comes from TMJ. So all these are features of osteoarthrosis. Now, this is associated with anatomical and radiographic changes to the joint architecture, such as destruction of cartilage, resorption of subchondral bone, synovitis, and osseous remodeling. Next, we have internal derangement of TMJ. It's a description of the situation in which the biomechanics of the joint have become dysfunctional as a result of displacement of the articular disc on the mandibular condyle. So what is, this is the scaphoid fossa of the maxilla. This is TM joint, and in between a disc, soft tissue disc is present. So this disc moves ahead, and when this disc moves ahead, then the condyle moves ahead. But while returning back, it faces an obstruction, that is, it has got deranged. Okay, so this is called as internal derangement. Displacement of the articular disc on the mandibular condyle. Okay, anterior displacement of the disc is most common. It usually gets stuck anteriorly, but it can occur laterally, medially, or rarely posteriorly also. Patients with internal derangement will often report to an audible clicking or popping sound on opening the jaw. So here, it's if the patient is having click, most likely it's a internal derangement of the disc. The condition is classified on the basis of position of the disc, whether it returns to its normal position, is it reduced, we will talk about it in the pictures ahead, and whether there is associated reduction in mouth opening or locking. Then we have TMJ disorder with myofascial pain. Now, it is, okay, first was joint structures were getting wear and tear of that. This one is disc related. Now it is more commonly with the masticatory muscles. The classification and nomenclature is contentious and complex, and the spectrum includes overlapping conditions from local to generalized myalgia. It is an extra-articular condition and the joint is anatomically normal. This condition is often called temporomandibular joint pain dysfunction syndrome, and inappropriately suggesting that condition is one of the joint. The patient reports a dull, heavy, diffuse ache like a chronic muscle pain, like muscle pain anywhere else over the body. So it is like diffuse, heavy when you run a lot suddenly. So that diffuse ache which happens, that kind of it mimics. And it happens over the side of the face, and pain tends to vary in severity. Classically, one of the two pain patterns is seen, pain being worst in the morning, slowly easing, or pain that worsens progressively during the day. The masticatory muscles are often tense and tender to palpation, and joint movements are often painful. The causes are multifactorial, poorly understood. However, it seems that muscle tension or spasm, local and central pain processing, and psychological response to stress all play a part. Next, we have why do temporomandibular joints click? Okay. Let's go into some anatomy of TMJ. It's a gangliomo-arthroidal joint that is condyle both sides, slides and rotate. Okay, so this is rotation on its own axis, and sliding is just moving front. Anatomically, it is composed of condylar head of the mandible, which articulates with mandibular fossa of the temporal bone. Unlike most other joints of body, these surfaces are lined with fibrous connective tissue rather than hyaline cartilage. So here we have fibrous connective tissue. In between is a biconcave fibrous discs. So the disc is concave in nature, so that the below condyle can fit in. And it is held in place posteriorly by the superior and inferior retrodiscal laminae, and anteriorly by collagenous fibers and lateral pterygoid. So this is how the normal structure of the TMJ looks like. This is the mandibular fossa of temporal bone. This is the joint, temporomandibular condyle. This is the disc, posteriorly connected with the muscle, and the retrodiscal fibers anteriorly connected with fibrous tissue. Okay. Now we have the structure creates a superior and inferior joint cavities filled with synovial fluid, allowing for both hinging and transitional movement. What is a hinge movement? Hinge movement is just hinge, and translational when it moves in, like moves ahead. Okay, so this is just the hinge movement, and this is me moving. The translation happening is translation movement. In normal mouth opening, initial opening results from a hinging movement that occurs predominantly in the lower compartment, which is by the movement of the disc and the condyle. As mouth is opened further, translation occurs in the upper joint cavity, and the disc and the condyle slides forward. So the thin part of the disc consistently lies in between the condyle and the temporal eminence. If the disc is anteriorly displaced, the most common direction where disc gets displaced is anterior. For example, because of laxity of the retrodiscal ligaments. Retrodiscal ligaments have to pull the disc back at its original place. But if they become lax, loose, they are not able to have that pull back of the disc at its original position. Then the thicker posterior part may restrict translation. When this is overcome, disc snaps back with a click and mouth. Opening can continue. This is known as opening click. On closing of the mouth, condyle can rapidly repositioned posteriorly, stretching the lax retrodiscal ligaments and forcing the disc anteriorly again. This creates an audible click or clunk and is known as closing click. If opening and closing clicks occur in sequence, the patient is said to have reciprocal clicking. So let us see here in the figure. This is how the normal mouth opening, TMJ opening is. This is the lower condyle. It glides forward. The disc first moves, it follows back. This goes in front. Now it has to return back, but there is laxity of the posterior fibers. It should actually, in the normal one, it returns back to its space originally, goes back and it's normal. However, clicks happen when it got displaced anteriorly. Now it is not able to come back at its position. So with the force, it comes back and produces a click while first click, opening click is on opening the mouth, and then click when it returns back, takes its position back into the fossa is the closing click. And what is with reduction, without reduction? Okay, there are two things written over here: anterior displacement with reduction and anterior displacement without reduction. Okay, so let us read in through here. Okay. Bottom shows partial opening in a patient with closed lock as a result of anterior displacement of the disc with reduced translation and opening. So reduction means the mouth opening is reduced, and displacement happens with reduction. Whereas displacement happens without reduction means there is opening is not reduced per se. So this is images shows movement possible in the intra and extra articular trismus. This green arrow indicates movements that are possible. Red arrows indicate those that are impossible. So in trismus, a little below green and condyle can move a little downwards. However, disc moving forward, downward, the mandible moving forward, downward is in the left intraocular trismus, close lock caused by anteriorly displaced disc. And in the middle intra-articular trismus, ankylosis, red, right extra-articular trismus, which is related to the fibrosis of the muscle. It can go in front, but not come down. So is it clear? Once again, let us see this part. In the first image, what they are trying to show, green arrow indicates movements that are possible, red which are impossible. So in the extreme left one, intra-articular trismus, it's a within mandible, the cause of, within the joint of the cause of trismus is closed lock caused by anteriorly displaced disc. This disc, yellow color disc, is anteriorly displaced. So this is a closed lock, and middle intra-articular trismus, here it is ankylosed, fibrous. So none of the movement is possible in this. In this, forward movement is not possible because disc has already slidden outside. This one, forward movement is possible in the case of the muscle spasm, but downward and rotational movement of the mandibular opening is affected. Is it clear a bit? Okay. So then they have asked about why do joints lock in the internal derangement. So inability to open the jaw indicates obstruction of the condyle during forward sliding or translation movement. The most common internal derangements to cause this is a grossly anteriorly displaced disc resulting from overstretched or ruptured posterior retrodiscal ligaments. The disc becomes fixed in the anterior fornix of the joint space and mechanically obstructs anterior translation of the condyle. Locking of the joint in internal derangement is rarely complete. It most often occurs after initial hinge or rotation movement of the condyle. The patient will complain of being able to partly open the mouth, but finds that it locks when the mouth is about half open. This is called closed lock, despite the fact that the patient can usually open and close a little. So it is uncommon for the patient to be completely unable to open the mouth. Close lock can be acute, but usually follows long history of reciprocal clicking. Open lock causes TMJ to be locked open and usually results from anterior subluxation or dislocation of the joint. Movements of the TMJ and mechanisms of closed and open lock are shown as we saw in the picture. So, this is what is the correct meaning of closed lock is locking of the joint in internal derangement is rarely complete. It most often occurs after initial hinge or rotation movement of the condyle. So initial hinge happens, rotation happens, and then it gets locked. Patient will be complaining that they are able to partly open the mouth, but finds that it locks when the mouth is about half open. So that is a closed lock. Despite the fact the patient can usually open and close a little. So it is patient was opening, but it has got locked. And it is uncommon for the patient to completely unable to open the mouth. It is not very common. Closed lock can be acute, but usually follows long history of reciprocal clicking. What happens in open lock? Locked open. It becomes, patient say, comes with a, now it is, they are not able to close it back. It is from anterior subluxation or dislocation of the joint. And the movements of the TMJ and mechanisms of closed lock and open lock are displayed later. So have you seen a patient with open lock? Suddenly a patient would come and with an open mouth, and they would say that they are not able to close it. So we have seen this kind of, I have seen personally once and heard of another patient who came with the mouth open position, and you have to manually, with the maneuver, you have to close the jaw. So give the force here, as the patient give a lower backward thrust, and it moves the jaw. So this is open lock and closed lock. Does this patient have an intra-articular or extra-articular cause for the locking? In extra-articular causes, the joint itself is normal, and thus, although opening can be restricted, translation occurs and lateral and protrusive movements are usually unaffected. In intra-articular causes, the joint is abnormal and translation of the condyle is usually the movement initially affected. Translation occurs in the upper joint space, which is where opening, protrusion, lateral excursion takes place. So usual translation the movement of the disc is in the upper joint space. So as a result, if cause is intra-articular, then movement is restricted in all directions because there is more deviation on opening and restricted lateral excursion in this case. The cause is more likely to be intra-articular, movements possible in intra and extra-articular trismus and locking. They were being described below. What is the most likely cause? She gives a history of chronic progression of painless clicking to rapid onset intra-articular trismus. It should be typical of internal derangement involving articular disc and anterior displacement causing closed lock. On examination, mandible is found to be deviated to the right, indicating condylar translation is intact on the left, but restricted to right. So synovitis, inflammation of the joint, is appropriate differential diagnosis, but history is usually of slow progressing pain, and all rather than just some joint movements are painful. So what tests you would do in this case? Lab tests, plain radiography. Ideally, you would refer such patients to oral medicine specialists for looking into the further investigations and treatment. Ultrasound, MRI, if there is a disc derangement, it will be helpful to get MRI. Arthrography, which is the study with contrast medium injected, diagnostic aspiration should be done. Treatment management, preliminary, we will go with the therapeutic guidelines, rest to the joint, overt exertion avoidance, yawning, and not giving exertion to the area. So this particular treatment for this cause, majority of the cases with closed lock related to internal derangement and an intact anteriorly displaced disc resolve spontaneously. It is generally accepted that conservative approach with appropriate review for 3 to 6 months is appropriate. This should be combined with targeted education and counseling. NSAIDs can be given, adjunct simple oral analgesia, warm or cold compress, and gentle mobilization as tolerated by the patient. Physiotherapy programs, joint mobilization, home exercises, use of passive joint motion machines, and construction of intraoral orthotic splint. Current evidence indicates that forced manipulation or manipulation under anesthesia provides no benefit over conservative management. So this is the case of trismus. And okay, is there any significance of the history in the history of hypermobility of the joints? Possibly being genetically predisposed to generalized joint hypermobility or suffering from two conditions you remember for hypermobility, Ehlers-Danlos or Marfan syndrome, would make the patient much more likely to suffer from TMJ internal derangements. However, internal derangement is one of the commonest TMJ disorders, and only a tiny fraction of patients have an underlying hypermobility disorder. Of note, joint hypermobility would not have been caused by this patient's childhood involvement in gymnastics, but likely indicates that she performed well in the field. So this completes our trismus unit from ODELL. We'll begin the next session with a new case. Thank you.